If you're watching this video, this is a shoulder surgery video. I'm going to go over all the different procedures in the shoulder and give you an overview of what to expect. With shoulder surgery, usually you end up in a sling. So you will be in the sling 3 weeks after the surgery, and then you'll start the physical therapy at that time. You come into the surgery center the morning of the surgery, and then you'll go home 2 or 3 hours after the surgery. I want to describe some of the issues associated with surgery and also what we would be fixing. So this is a model of the shoulder. This is the humerus. This is the glenoid here. Scapula is here. The clavicle comes out to the acromion. Oftentimes when people get problems in the shoulder, it is secondary to impingement. What happens is that as the shoulder gets pulled up, as our rotator cuff in the front and the back gets relatively weak, the deltoid over pulls, so it pulls that humerus up into the acromion and ends up pinching this, which is the rotator cuff tendon. The rotator cuff tendon on top is the supraspinatus, and that is the one that is torn 90% of the time. The subscap in the front and the infraspinatus teres minor behind much more infrequently get torn, although the subscap sometimes does. If this does tear and it's small, we can sometimes treat it conservatively, and that would be with injections and physical therapy to improve the strength of the front and back muscles so it holds the head down and gets it to clear better under the acromion and doesn't pinch on the rotator cuff. If that fails, if the injection and therapy doesn't work, or if the pain is just unbearable and keeps you up at night, we sometimes have to operate on those small rotator cuff tears. As the tear gets bigger, the head depressor effect of the supraspinatus goes away, so the shoulder rides higher and it pinches against the acromion, and that causes more pain. In that situation, surgery is recommended. With the surgery, we do an arthroscopic approach. We have a portal in behind, one portal in the front, and 2 portals on the side, through which we would go in and, number one, shave off that bone spur, because the bone spur contributes to the tear, number one, and also it could contribute to a re-tear if it keeps pinching on the rotator cuff insertion site. So we would shave that bone off. Depending on how much arthritis you have at the clavicle on top, we can sometimes remove that as well to decrease the pinching between the clavicle and the acromion. And then we would address the rotator cuff. When the rotator cuff is torn off the tuberosity, there's exposed bone. So we want to prepare that bone by burring it down so that there's a bleeding bed on which to reinsert the rotator cuff into. I personally use an arthrotunneler device, so it drills from the top. It has a deployable metal loop that goes down. I drill from the side, capture it, drag the suture through the bone, and then we feed that through the rotator cuff and reattach it back down to the bone. One of the important things I want to stress is the importance of the sling and not using the arm much early in the postoperative phase. We put the tendon back down to the bone, but if you move it too much, there can create a film, a fibrous film in between the tendon and the bone, and that can inhibit the healing process. So I want to stress that we want to keep it relatively motion-free for the first 3 weeks after the surgical procedure to allow the healing to initiate. Other procedures that you could be getting done would be the biceps. The rotator cuff here pinches against the acromion, but so does the biceps tendon, which is right next to it. So that biceps tendon can get frayed, it can get torn. It can get torn because of a tear in the subscaps, which means that the biceps that sits in this groove comes over and back and ends up getting a split tear to the biceps. So occasionally associated with your shoulder surgery, you might need to get a biceps tenodesis. What that means is we remove it from the shoulder because that is a pain generator both in the shoulder and in the groove, and we do a small sub-pec incision where we go in and underneath and reattach it back down here to give you better biceps function and better biceps contour. I've done this 20 different ways over the last 16 years, and I feel this is the best way to completely remove your pain. One other surgery that I want to comment on is shoulder instability. So another shoulder surgery would be for dislocating shoulders. As people dislocate the shoulders, 90% of the time it comes out anterior or inferiorly, and you develop these lesions called a Bankart lesion or a Hill-Sachs deformity posteriorly. What a Bankart lesion is you tear off the labrum. You can either get torn anterior labrum or you can tear it all the way around. In that case, we would need to go in arthroscopically and reattach that labrum back into position to decrease your chance of a recurrent dislocation. Current literature states that individuals between 18 and 35 years old, the recurrent dislocation risk with a Bankart injury requiring a reduction is over 90%. So in that population, usually we would tend to repair them more often. If you're an elderly person and have a dislocation to the shoulder, you're at risk for a nerve injury, and you're also at risk for massive tears to the rotator cuff. And so we need to evaluate that prior to any consideration for surgery. So that is a brief overview of surgical issues associated with the shoulder, with the exception of total shoulder and reverse total shoulder, which I'll talk about in another video.